So my name's Lily Hoffman, and I'm from NYU Med School, placed at Bellevue Hospital in the emergency department. And I have worked closely with Dr. Ryan McCormick, who started this on the Bellevue side. And he initially was supposed to be at a different conference, but is actually here today, so he's in the front row if you have questions or criticisms. So we did a 12-month analysis of this pilot based on patients' hospital use pre- and post-placement in housing. We looked at 20 patients because it was 12 months, which is different from the 26 patients. The 6 others were placed either before or after that 12-month period of analysis. So 16 patients were placed. The y-axis represents the amount of months since initial placement, and each bar represents a specific patient. So 4 patients had an increase in ED visits, and as you can see, the rest of them had a decrease in their ED use post-placement in housing. We also looked at their inpatient use. So this is a summation of the group of 16, their hospital use. Their ED visits were reduced by 38% as a group. The inpatient days stay was reduced by 35%. And then, as you can see, their clinical visits went up. So that includes outpatient alcohol rehabilitation, medical clinic appointments, and that went up by 814%. So that is really our goal too, is to shift their point of care from emergency care into primary care, ideally. We also did a cost analysis of the 16 patients who were placed. As you can see, the ED costs went down by 43%, inpatient 32%. Obviously, there was an increase in the clinical costs. And so we looked at this by looking at the 6 months prior to each patient's respective date of placement, and then compared it to that post-placement period, which was around 8 months. In the 6 months prior to placement, these 16 patients cost $1.16 million at Bellevue Hospital alone. So that's about $72,000 per patient, which averages out to $12,000 per patient per month. After placement in housing, that cost was reduced by about $4,000 a month per patient. So obviously, in addition to the moral reasons that we need to help this population, they're a huge cost. And I also just want to remind you that this is at Bellevue, so that we also know that these patients are using many different hospitals in New York City. This is one case study. This is Bellevue Emergency Department's highest user, who was homeless for over a decade and had over 1,000 visits. The arrow indicates his placement, his first placement in housing services. And as you can see, again, this illustrates really what would be great to have happen with all of our patients, which is that the ED use decreases and their outpatient use significantly increases. So this patient was attending drug rehab outpatient consistently, and also was really able to create a community there, which I think is significant. So that's sort of a brief run-through of these preliminary results. I think one of the biggest outcomes that we've learned is that this term, chronic public inebriate, really doesn't describe the population in the way that it should. So as you can see, there's this persistent heavy drinking, but it's also complicated by many medical comorbidities, which we're in the process of studying now. These patients are not just drunk, which is commonly how they're perceived both in the emergency department and in the social services that they access. They have cognitive and psychiatric manifestations of their drinking, and as I said, comorbidities, both medical comorbidities and mental health comorbidities. This patient population at Bellevue, the CPIs, there's an 8.6% mortality rate per year, which is significantly higher than the general population. So these patients are very sick, and they're dying, obviously. So there's a real need to intervene, and their access with the hospital is obviously very high, yet they continue to have very poor health outcomes. So there's a real need for collaboration, obviously, as you've heard from Sam and Joe, and specifically because not only are there these medical comorbidities, but they also have social vulnerabilities. So working with three different institutions, it creates accountability and creates communication. If a patient has 5 different case managers and they're not communicating and they're unable to share that patient's records, then that's a lot of time and resources that are being wasted. And as you can see, it has improved their outcomes in terms of visits, and I think it's also improved the outcomes because it's required providers to reconceptualize this patient population. So it's required both doctors and social service providers to look at these individuals and really recognize them for their complex needs and then the sophisticated kind of interventions to meet those needs. And so we sort of use the term meet them where they're at. Literally, they're in the emergency department, so that's where we're meeting them. And there were certainly challenges. I started working with Dr. McCormick a couple years ago. He was consenting patients as an ED physician and calling mock outreach on his own at 4 a.m. And it has certainly built over time, but that has taken a lot of buy-in. Bellevue is a huge institution, and one department can be committed to the pilot, and you can have a patient plan, and when they're admitted as an inpatient, that plan, if it doesn't get communicated, the patient leaves against medical advice, and we're back at square one. So there's a lot of buy-in and engagement and constant communication that is necessary to really make this work. And I think going along with that, it's this idea of reshaping how we look at addiction and how we look at this patient population. So it's changing the typical trajectory of these patients, which is that they're picked up on the street by the ambulance, brought to the emergency department, and when they sober up in a couple hours, they walk out on their own. So this has been a process that's continued for a very long time, and I think one of the perks of having mock being able to come is that it gave physicians also a sense of hope that someone's going to come and take care of this patient, and so I am going to be more engaged in their care. And it also, studying these patients has allowed us to realize really how complex a severe alcohol use disorder is, and how that manifests in patients' decision-making, in their impulse control, and how it manifests in their brains and in other medical conditions. And the privacy and confidentiality Joe spoke about a little bit, but it's very difficult to share information on these patients, and I think that's one of the biggest sort of challenges that we have at this point, is that this is only at Bellevue Hospital. So patients can still go to other hospitals. We have no communication with them. We don't have their records. So it really needs to be a citywide initiative and needs to have that support in order to be the wraparound that we would hope. This is our This is our inspiration. So yeah, thank you very much.